My name is Annette Brown, and I am a associate professor at the University of Utah. And today I'm going to talk about respiratory support for spinal cord injured patients. I think it's important to start out with a case, not just because it helps us to put the information into context, but also because it always gives me the why. This is a real patient that I took care of, that I've known for a long time now. But walking with him through his journey of acute care to rehabilitation care to home has been really important for his quality of life, but also for, I think, understanding of us as medical providers. I do practice in the United States, so I will acknowledge at times different caveats of our system versus other medical systems that may be around the world. But it's just worth considering some of the similarities and differences at times. So this patient is a 7-year-old male in unknown past medical history when he came to us in the acute care setting in the ICU. He was riding a motorcycle and had rear-ended a semi-truck after failing to stop in time. He received CPR at the scene by one of his co-riders, and he was actually intubated at the scene for low level of consciousness and difficulty breathing. And he was found to have a C5 spinal cord injury and associated fracture at that level, and was immediately, upon arrival, taken to the operating room for a 4 to 6 fusion and stabilization. So back in medical school, I learned that C3, 4, and 5 keep the diaphragm alive. I found that very easy to remember, but it also still rings true. Another factor that you need to remember, though, is that the diaphragm provides 65% of the tidal volume during normal respiration. But there are other variables, including the intercostal muscles, which are innervated by segmental spinal nerves coming from T1 through T11. And those are lost in complete tetraplegia, and they may also lose those accessory chest muscles, which can be important as well. And it's important to remember also that exhalation, when we exhale, is a passive process, but you need your abdominal muscles for augmenting contraction and expulsatory force. And that's important for an effective cough for secretion clearance. And in spinal cord injuries in general, it's just important to think about our population and who we're taking care of. Those traumatic injuries, such as motor vehicular accidents, are responsible for most spinal cord injuries. Younger men, males, tend to be more injured in motor vehicular accidents, and older patients tend to be more likely injured in falls. Although our patient is a little bit slightly different here in a motorcycle accident. In the US population, it's estimated that 1.9% of that population, with approximately 6 million people, live with paralysis. So this is a condition that impacts a lot of patients and for a lot of years of their lives after the accident. And then there's roughly 54 new cases per 1 million people per year. And roughly half of those new spinal cord injuries are cervical spinal cord injuries, which have the added factor of impacting the respiratory system. And also important, this is a wildly variable estimate depending on the population you look at, but anywhere from 27 to 75% of spinal cord injury patients will receive a tracheostomy. And unfortunately, at times, though, compared to those who can wean off, those who remain ventilator dependent following discharge have demonstrated lower quality of life, higher mortality rates likely related to infection, and more frequent hospitalizations. And so it's important, again, to consider the level of injury when you're talking about a spinal cord injury. Death and traumatic brain injury often occur most frequently due to respiratory muscle paralysis and apnea. So it's also important to recognize patients who have injuries that may impact that region, especially in those initial trauma patients where you may not be able to accurately assess them because of sedation and altered mental status. And then the risk of ventilatory failure is highest in the first week after injury, but there can be some other variables, including spinal shock and evolution of injury, that are important to keep in mind as well. Um, and then pulmonary complications of the lesion cause of short-term and long-term morbidity and death. Um, I often tell my patients, caregivers, and staff, you know, airway secretion clearance, things like that aren't the most exciting things we do all day, but they have a huge impact on the patient's quality of life and quantity of life. And again, with a level up to 84% of C1 through 4 injuries experience respiratory compromise, and up to 60% with 5 through 8 experience it as well. So even with someone, say, a C6 through C8, you wouldn't necessarily directly think that their diaphragm would be impacted. Um, it's important to keep in mind that, imaging is not perfect, and neither are exams, and you may have a patient that is still having respiratory compromise. So it's incredibly important to assess for that. Um, and this is a figure that kind of helps me think through some of the variables that are important in spinal cord injury. Um, so you have the spinal cord injury itself leading to respiratory muscle weakness. Then you have reduced lung volumes, followed by the impact of sleep, where in the deep stages of sleep, you're primarily using the diaphragm, which is impaired in these patients. And then you have increased CO2 dependence or drive of breathing. You can have intermittent upper airway collapse, which could impact, and then adding to apnea and hypopnea and breathing instability. And this pathway can lead to full-on respiratory collapse and need for intubation. So our patient, again, unfortunately at the scene, nobody's completely sure, and this happens in a lot of trauma with intubation, whether there was some aspiration. He developed pneumonia. He had significant secretions and was treated with antibiotics and airway clearance. At one point, his secretions were bad enough he actually required bronchoscopy. And then weakness and sedation were an issue as well. In the ICU, obviously in, there's a incentive to, wean sedation and for patients to prevent delirium, but it can be difficult sometimes too, when they're not completely off sedation, to have them following commands and assessing their level of injury. And that's what was happening here, is we weren't sure when he was actually having sensation or motor function. So it was pretty clear by his operating room details and his imaging that he had a pretty high injury, but how complete it was still unclear. And this is where I think it's important to consider the global nature of spinal cord injury and the differences in facilities that we use for helping patients, whether that's in the ICU, whether it's in an acute rehab center, or dedicated centers towards spinal cord injury. This data can be colored by this, so take that with a grain of salt. But here in the United States, one of our patients may be in a rural environment, for example, in an ICU where they have combined medical and surgical patients. So you may not have someone who is experienced caring for a lot of spinal cord injuries, all the way to our facilities, which do nothing but caring for spinal cord injury patients. So it's just important to know that the data is going to be impacted by, depending on who's reporting those things. But ICU extubation, there's the bicycle score that has been used to assess patients and their likelihood for weaning success. There's also just the global data, which looked at ICU extubations and where failure can be as high as 1 in 5. And this can be challenging because that can be due to a lot of factors. That can be due to the injury itself, all the way from secretion, sedation, weakness, etc. And then, depending on whether it's a complete injury, a non-blunt injury, a high injury severity score, and then increasing age as well. So unfortunately, our patient is not in the best of categories, being that he's an older gentleman. But those unfortunately are associated with a lower probability of weaning success. And so that's part of what goes into whether I think patients get weaned initially or not out of the ICU. And then practice patterns. Here in the United States, there are probably some factors that really do lead to more early tracheostomy placement, because that can allow them to be discharged to rehabilitation centers, or what we call here in the United States the long-term acute care facilities, or LTACs. So there may be some non-clinical or non-patient related variables that lead to patients having a tracheostomy placed. And then, as I said, the experience and frequency of caring for spinal cord patients, if this is something you do once a year versus something you do every day, that's going to change your practice patterns as well. And as part of the reason for doing these educational seminars is to make people aware of some of the variables that are important. And then variability in an imaging interpretation combined with preliminary neuro exams in the ICUs, and then limitations by sedation, and can lead to misclassification of spinal cord injury patients. I know myself, I have had patients sent to me that were, quote, unweanable, that we later weaned after, fixing some of these variables. Short of like transection of the spinal cord, it can be very hard to say, how damaged that cord is and what function they will regain. And so it's just something important to keep in mind when you're seeing these patients initially, and not get too stuck on what someone else may have said about the patient's probability of weaning. And again, different environments may also make it more likely or less likely to have success in weaning. And I think this piece of data shows it right here. And in rehab hospitals, reported weaning successes varied between 7% and 100%. So that is probably one of the widest ranges I've seen for data. And, the mean rate of 68%. Again, I think there's so many variables that go into that, which is why there's such a wide range there. And then prior studies in inpatient rehabilitations have found, lower injury levels, high vital capacity, and an intact diaphragm motor unit requirement on EMG were associated with higher rates of weaning. So definitely people have looked at what are the positive variables here, but not everyone may have access to, say, diaphragmatic EMG, for example, which is primarily only found in higher level centers. And then this is, again, why it's important to think about this. The pulmonary complications, as I've said, are, leading to obviously morbidity and mortality. And atelectasis is actually the most common, followed by pneumonia, followed by full-on respiratory failure in all injury levels. And then pulmonary effusions, interestingly enough, can also most frequently occur with T1 through T12 level injuries. That's why imaging can be very helpful if you have a patient that was doing well that's suddenly not doing well. And then thoracentesis or chest tubes can be helpful with managing that. And then pulmonary edema from resuscitation efforts, I definitely acquire a lot of patients that are particularly volume overloaded, and diuresis may be helpful with this as well. And then pulmonary embolism, 4.5% of patients in the first 3 months, this can be a real problem, especially if it's a traumatic injury and they've had bleeding complications. I manage a lot of patients who have traumatic brain injuries and head bleeds as well. So that can be particularly tricky. And then this is always a factor that I have found interesting. You can see bronchospasms in injuries about T6 with unopposed parasympathetic activity. You can have a patient who has never had any asthma-like symptoms in their life, and then after their spinal cord injury, suddenly is having wheezing and more secretions than what would be expected. And this can be a reason for that, and also something to look for in your patient population. And then the other one, which I'll show more data about later, is obstructive sleep apnea. Depending on the patient population that you look at, OSA is pretty frequent in a population, but I've typically not seen the estimate greater than 20%. But after the injury, and it's unclear what exactly the mechanism of injury is that leads to increased OSA and sleep disordered breathing, but is definitely worth considering in your patient too if you're having more issues at night or with sleep. Um, and then obviously impaired cough and secretion clearance, which we'll talk more about in a minute. So these are just examples of atelectasis versus pneumonia. On the left-hand side of your screen, you can see a very distinct plate-like atelectasis. And on the right-hand side, I'm showing you an example of a very clear pneumonia where you can see an air bronchogram running through that. These are very clear examples, and in reality, I find sometimes it can be very challenging to separate this out by just X-ray. And even when you look at CT scans for our patients, sometimes, it's, the read will be something like atelectasis versus pneumonia, correlate clinically, which, sometimes is helpful, sometimes is not. But it's important to keep in mind for this if you have a change in oxygen capacity or ventilatory capacity, to go back to your imaging to see if there's something new. Also, for many of our patients with traumatic injuries, you have a lot of dysphagia and tendency towards aspiration anyway. And so that's just, a variable that you also have to keep in mind. And so, Dr. Michelle Chatwin published this really great state-of-the-art review in respiratory medicine. Highly recommend looking at this. I like this particular diagram because it really breaks this up into cough augmentation versus sputum mobilization. Often when I'm receiving patients from other facilities that don't usually take care of neuromuscular patients or spinal cord injured patients, they're focusing a lot on the sputum mobilization, but they're not really thinking a lot about the fact that the patient really needs a lot of help with cough augmentation, which is basically that assisted inspiration and assisted expiration. You can use other techniques like glossopharyngeal breathing, air stacking, but I find that if you're at a center that doesn't do a lot of that frequently, it's harder to get people to do it, frankly. And really, when it comes down to, you're going to use the mechanical insufflator, exsufflator, which is commonly referred to as the cough assist device. And really what you're helping them do is take that large, deep breath. You're helping them exhale and be able to pull secretions out, but also do those large re-recruiting breaths to help break up that atelectasis and a number of neuromuscular conditions. The cough assist has been shown to reduce the incidence of pneumonia and also help with hypoxic episodes. And then on the right-hand side of this slide, it's important to also consider the adjuncts for sputum mobilization. We use high-frequency chest wall oscillation or vest therapy. You can have interpulmonary percussive ventilation with a number of different devices here in the United States. We had the Medeneb and now we have the Valera. And then chest wall strapping, I can't say that I use, or it's not something I run into frequently, but is an option as well. So it's important though, when you have a spinal cord injured patient, to not just use the sputum mobilization techniques. You really have to add the cough augmentation as your mainstay of therapy. And then the other thing to think about is sputum sample. Where we are now, we have some newer techniques to be able to run PCR samples off of our sputum to be able to get quick responses back as to, are there anaerobes present, are there viruses present, other things you wouldn't be able to routinely be able to culture on a sputum sample. And what we're finding with that is actually it's great to be able to de-escalate your antibiotics, because unfortunately a lot of these patients get hit with multiple rounds of antibiotics. And then what you're dealing with is very resistant bacteria, and this could be huge for their long-term health. So being able to tailor our antibiotics, also sometimes too, I'll use the sputum gram stain to see if it's got a lot of neutrophils on it, indicating a lot of inflammation. Maybe I need to target that as well, in addition to just bacterial infections. And then considering whether, based on our x-ray, whether this is more of a tracheitis scenario or whether it's a pneumonia. And then again, what we talked about on the other slide, are you mobilizing the secretions? Are you helping to augment their cough, which is key? And then nebulizer treatments can be helpful as well. Like I stated before, when you have increasing bronchospasm in a patient because of the parasympathetic activity, pre-treating for cough assist with albuterol or using duonubs can really help bronchodilate those airways open so that they're then able to clear those secretions more effectively. Vest therapy can be helpful. Unfortunately, in the United States, I have struggled to get that for adults. It's much easier to get it for children. And then hypertonic saline is a little bit controversial. I will also add N-acetylcysteine to that list. They have done studies which have not really shown a lot of added benefit. There are definitely some folks that are really believers in it. I will tell you though, as a pulmonologist who works with a lot of COPD patients, there are data though with hypertonic saline, you're actually decreasing your FEV1 because it is an airway irritant. So I would say these are definitely adjuncts, and for some selected populations, they may help, but you actually may have times where it's actually not helpful and counterproductive. So I would take that with a grain of salt. And then what are we doing with the ventilator? This is true for both the acute care ventilators, but also the long-term ventilation. This is a very nice review for JCI for the mechanisms of ventilator-associated injury. We know within the early days of ARDS that if you use high volume ventilation, that you're more likely to end up with what's shown here on the left side, which is a lot of inflammatory changes. And then if you use low tidal volume ventilation on the right side, you don't get nearly as much of that. And so since the days of ARDSnet, I think there's been a lot of changes in how you manage acute ventilator-associated injury. There used to be a tendency towards using large volumes for spinal cord injured patients. And so I think those days are limited. I don't see those as much in talking to my colleagues around the world. I feel like that is less and less popular. This is a newer paper that came out looking at tidal volumes of greater than 15 cc's per kilo versus lower, less than 15. But I will tell you that mostly what I see now is more targeting normal capnia, which is usually in the ballpark range of about 8 cc's per kilo. But what they found with these patients was that there were high volumes were associated with increased risk of pneumonia and adverse pulmonary events in trachea. These patients already had tracheostomies, but I feel like in general, though, part of also why people wanted to use high volumes was because at the time there wasn't the cough assist and other similar devices readily available. And so people were trying to prevent atelectasis and mucus plugging with these high tidal volumes. But now, given that we have those devices more readily available, I feel that people are more comfortable in general trying to use these smaller tidal volumes. So ideally, trying to target normal capnia, ballpark about 8 cc's per kilo, 6 to 8 cc's per kilo, especially in the, more fresh injuries. And then as time goes on, we're still trying to find that ideal tidal volume for long-term ventilation, but I feel like it's closer to normal capnia and 8 cc's per kilo. But like everything in medicine and science, it's probably a moving target. And then this again, every time I look this up, I want this to be better, and I want somebody to have given me a better answer, but we're still working on this. Ideal weaning mode. Even in regular patients that are non-spinal cord injured, there have been several studies, Cochrane review. There's no significant difference between TPEACE trials and pressure support trials regarding extubation failure and mortality, and this has a low quality of evidence. Clearly, that's because we're comparing a lot of different patient populations in studies, and it just can make it hard when you're at the bedside day to day to try to figure out what is the ideal weaning mode. There is one caveat though. Pressure support was found to be superior to T-piece in a proportion of successful spontaneous breathing trials in patients considered to have simple weaning and moderate quality of evidence. Those are the easy patients. The reality is in our spinal cord injured patients, we have a lot of variables, especially if they're polytrauma. Um, I have personally found that weaning with a rate as a backup if the patient is fatigued, but then being able to, take the rate off and decrease the level of uh, pressure support for those patients over time, and increasing the amount of time that they're doing those weaning trials has been successful for us. Um, that being said, and I've seen that in other recommendations as well from other authors, but there is no head-to-head trial out there that will show you that. And one factor that I also incorporate too is, as we're doing a lot of therapies for patients, if you fatigue them out by making them do too long of a trial, that could be counterproductive. So talking to the patient, talking to the caregivers, and increasing those weaning times where they're without a backup rate, with their pressures lowered over time, um, has been the most successful for me so far, but um, keep in mind that the level of evidence for that is lacking. Um, the one thing I did want to bring up though in the ICU, and this gets the bicycle score and some of the other predicted variables, is often many of us will use what's called a RISB, which is the Rapid Shallow Breathing Index, and looking at the ratio of respiratory frequency to tidal volume. And, what I learned when I was a baby intern in the ICU, that, a RISB less than 105 is um, versus above 105 is better at identifying patients who will fail weaning, identifying patients that can be successfully weaning. But keep in mind that there's no evidence that a RISB dependent weaning improves clinical outcome, and such as your duration of weaning, duration of mechanical ventilation, length of stay, and reintubations rate. And the biggest caveat of this data is they excluded neuromuscular patients. So I have seen this in my own ICU where people are like, "Oh, well, their RISB is this, and their NIF or MIP is this," and I'm like, all those studies excluded my patients. So it's really important because that's not what this data was for. And obviously, if you have low RISB, you feel better about it, but it's not definitive in this patient population. And so there are some protocols that have looked at this. Probably the most famous is John Bach's Bach protocol, looking at peak cough flow, predicting success, and more closer to what our patient population is. Looked at neuromuscular patients who failed SBTs before and after extubation, and then looking at this particular protocol, using a lot of non-invasive support and airway clearance, was able to get a pretty good success rate for those patients at 87%. But that being said, this requires specialized center and a lot of intensive care from a respiratory therapy standpoint, which can be a real limitation in other facilities, frankly. And then there's another study from back in 2011, small, 7 out of 10 patients were successfully extubated using a similar protocol, except for manual assisted coughing versus mechanical, like cough assist, depending on the patient's ability to cooperate. So this is definitely something, though, that I will try to incorporate in our ICU patients if I get called about them, to really emphasize that don't be dependent on numbers that may or may not have a bearing on our patients, but also using a lot of non-invasive support and airway clearance. And so this is kind of what I do. Again, limited evidence, but using a lot of the mechanically assisted cough assist, 40 centimeters plus or minus, extubation, and then directly extubating them to non-invasive positive pressure ventilation, and then using other adaptability pieces that are available on a number of our ventilators now, using either mouthpiece ventilation or nasal mask. This can be a caveat in the ICU, though, because some of those staff may not be used to what are typically considered the home ventilators. So I have to get people to think creatively sometimes, or use things they're not used to. But this can be great for providing that kind of in-between bridge while they're healing from, say, a pneumonia or their injuries, things like that. And then again, really using that cough assist like devices to be able to clear those secretions, or other devices such as the Metanev Valera for sputum mobilization. And then our case continues. Due to ongoing issues, unfortunately, with our patient and weakness, sedation, secretions, unfortunately, he had to have a tracheostomy placed. Further discussions with his wife actually indicated that he probably had obstructive sleep apnea before his injury. So I'll talk about some of the obstructive sleep apnea and how that impacts our patients in a second. And then his accident might have actually been triggered by a syncopal event. We did see in the ICU that he was having some bradycardia, so he actually had a pacer placed. So, and I bring this part of the story up because a lot of the times when we're assessing trauma patients, we're trying to figure out the basics. We're trying to keep them alive. You may not know their respiratory history. You may not know their sleep and apnea history. And so this is the part, as the dust settles, it's important to go back to the family or friends or whoever and actually try to get a better understanding of what their medical history was like, which you may have not been able to in the initial trauma part. And so getting to these patients, any data can really help you. So it's important to consider old pulmonary function tests if available. If you can get a forced vital capacity seated or supine now, that's also helpful. Supine forced vital capacities can be very helpful in understanding which patients are having difficulty with being in the supine position. Looking at diaphragm strength with NIF and MIP can also be helpful. Peak cough flows for those patients who have more, lower cervical, higher thoracic, this can be helpful because just the specific level of injury may not tell you that they're completely weak and not able to, clear their secretions. So I look at this as sort of the canary in the coal mine. PSGs or sleep studies sometimes can be done in facility, sometimes at home, or being able to, in the case of our patient, pull up an old sleep study that indicated that he had sleep apnea. And then old medical records for previous diagnoses. I have definitely had my share of patients that, got into a car accident, but also had terrible COPD at baseline, which may really impact your ability to wean someone ventilator. So back to our patient. He continues to improve with secretion clearance, and his mental status improved as well. He was actually pretty funny when he woke up, and was very interactive and very motivated to participate with therapies, which is also a key portion of it. He was admitted to our acute rehab facility for active ventilator weaning. We used a combination of SIMV with a rate for rest and increased time on pressure support with no rate and decreasing that pressure over time. And he was able to wean off the ventilator during the daytime prior to his discharge home. We left his trach capped during the daytime, but then he would use his trach for support at night. And then he continued to wean off the ventilator completely over the last the 6 months after discharge from the facility. And the key part of that, though, before we decannulated him, was we did a repeat sleep study, which confirmed his sleep apnea again. And then after decannulation, he went to CPAP at night, and I'll explain why that's important as well. So this was data identifying sleep apnea and sleep disordered breathing and nocturnal hypercapnia and spinal cord injured patients. There were 91 patients with a wide level of injuries, C1 all the way to T6. And this was a nice thing because you were actually able to do home sleep tests. A lot of our patients struggle with their equipment needs and their caregiving needs to go to a standard inpatient sleep lab. So that was also combined with transcutaneous CO2 measurement at home. And it found that 81% of patients with spinal cord injuries of this wide variety of levels had obstructive sleep apnea. And even more, 23.8% actually had central sleep apnea as well. So much higher than what you would expect in a general population. Clearly, there is something related to their mechanism of injury with their spinal cord. But it's important to know that this is very much in line with the other data that's out there, that it's a high frequency of this population. And so you can use a home sleep test to be able to detect these patients. And then why do you care about finding them is because um, if they do have OSA or hypoventilation, which is the more severe form, you can treat them. And in this case, even in short amounts of time, even below 4 hours of treatment for OSA or um, hypoventilation, actually showed improvements in their OSA, improvements in their nocturnal hypercapnia, and higher pressures actually, ironically, were predicted with better adherence. Sometimes we think, oh, well, if I start them off on lower pressures, they'll be able to tolerate it. This patient population, if you don't have enough support, they can feel like they're drowning with non-invasive ventilation. So this is super important, regardless of how you're doing this, to, make sure that you've got adequate pressures and not be afraid to really start with higher pressures, higher driving pressures, especially if CO2 is a problem. But this was the part that we were really surprised by, is not only did we find that they had less respiratory complications, which was sort of why we did the research, but we actually found they had decreased incidence in autonomic dysreflexia and orthostatic hypotension that normally can really impair their quality of life and impair their ability to participate in activities. And was something, as I've talked with patients in getting them to understand why we want to do treatment for OSA or hypoventilation, is actually something that really motivates them because it impacts their quality of life. So I tell them, you get the additional benefits. And one thing we don't know in spinal cord injured patients is whether also treating their OSA will lead to decreased stroke and heart attack and other cardiovascular risk factors long term as well. So that's something that we'll need to look at, but just really important to think about for your patient population. And then, realistically, there are some patients you can't wean for a variety of reasons. Some patients may need full-time ventilator support. I also don't consider it to be a failure, frankly, if you're able to get them to a point where they can just use ventilator at night, because a lot of patients will tell me that it's huge to be able to just be free of stuff during the daytime, um, but maybe retain their trach in a way that's capped. But sometimes you can't do that. The severity of injury, transection of the cord, they might not be able to wean from the ventilator. I have had some also spinal cord infarct patients, which are a different mechanism of injury, but can be challenging that way as well. And at that point, I have a discussion with the patient about their goals for their day-to-day living and mobility and what they want to do from an adaptive device standpoint. Some patients prefer to stay on the ventilator. They find it easier to do secretion clearance with it. They have larger voice volume, which is huge for communication. And kind of talking about the pluses and minuses. Some patients, on the other hand, are really want to get rid of the ventilator, want to get rid of their trach. Another option is using diaphragmatic pacing. These devices have been around for a while and basically use different electrode setups, either by Avery or Synapse, to be able to stimulate the diaphragm. So this is closer more to a negative pressure ventilation than a positive pressure ventilation setup. These devices are obviously implanted, which has its own pluses and minuses. You can't get an MRI. And depending on the device, you may have chronic wound care, or, if you have infections or other things like that, can be kind of a negative. Voice volume is a little bit different with these, and that's one of the things that I've had patients get these and decide they don't like them, which is kind of an unfortunate scenario. But voice volume can be impacted. The other thing is that they don't sense. We can adjust ventilators to be more, patient driven when they want a breath or how they want to speak. And even on a ventilator, patients have to learn how to speak, again, differently than how you and I converse. And then with the diaphragm pacers, they just give you a rate. So they have to learn to talk with that rate. And you can adjust the rate, for that. But this can just be something the patient has to be aware of when they're kind of choosing what they want to, what devices they want to use. And so I tell my patients, I'm happy to manage either device. This just really you kind of have to go in eyes wide open for this. And realistically, when you're screening for these devices, you can test to see if there's phrenic nerve injury. But unfortunately, there's no perfect definitive test, and realistically, you can go to the OR and realize that they don't stimulate based on, severity of injury, and that can just be challenging sometimes, is to have a procedure, but without being able to place a device. So just important to know that there are resources out there, different options out there, but everything has its pluses and minuses. And so, um, I just wanted to say that I've been really grateful to be able to take care of the patients that I've taken care of. And they have taught me a lot in managing both, acute ventilation, rehab scenarios where we're able to wean those patients off the ventilator, and then long-term support with either non-invasive ventilation at night for hypoventilation, BiPAP or CPAP for OSA. And I think that as technology continues to improve and mobility and other things are a factor for this patient population, we're going to see a lot of people that are able to get back to a quality of life I don't think they or us ever imagined. So I'd just like to thank Brace for the opportunity to speak here, and thank you.